Cast is now starting. All attendees are in listen-only mode.
Well, hello everyone, and welcome to today's webinar entitled HPV and RRP. Why do we need to do more to prevent recurrent respiratory papillomatosis? Provided by the Consortium for Infectious Disease Control, or CIDC, located in Winnipeg, Canada. My name is George Wertak, Executive Director of CIDC. This webinar is made possible with support from Merck Canada and with assistance provided by BD Diagnostics and Immunize Canada. Thank you for joining us today as we learn about recurrent respiratory papillomatosis, a disease caused by HPV. The moderator for today's webinar is the chair of the Canadian HPV Prevention Network, Dr. Marc Steben, and I will pass the microphone over to him in a moment. We're delighted to have Dr. Paolo Campisi from the University of Toronto and the Hospital for Sick Children join us to share his expertise. Now, I am pleased to report that this webinar is being broadcast to over 350 locations. Now, as you can see on the screen, there is a list of webinar objectives for the program. These objectives will be addressed during Dr. Campisi's presentation. I'll allow you a few seconds to read through these while I provide some notes. Note that this webinar will be recorded, and the recording, as well as the PowerPoint slides, will be available following the webinar. They'll be archived on CIDC's website, and the address is www.cidcgroup.org. CIDC offers a number of useful resources on its website and also manages the Canadian HPV Prevention Network, which is a community established to encourage exchanges between medical professionals on areas related to HPV prevention, treatment, and education. If you're interested in joining this HPV network, please send a message via the contact form on the CIDC website. There is no cost to join the HPV network. Now, I have a few housekeeping items to deal with. All participants have joined the webinar in listen-only mode, meaning that you are muted. You can hear the audio via either computer speakers or by telephone, but we encourage you to use the computer speaker setting. But if you do have sound trouble, you can select the telephone button and then dial in with the number and code that will be displayed. There's also a questions pane where you can type in your questions at any time during the webinar. Type in your questions in the box and then press send. Questions will be saved, and all or some will be answered following the presentation during the question and answer period. Again, all participant lines have been muted, so please type in your questions. If we do not get through all the questions, Dr. Campisi has kindly agreed to try to find time to answer at least some of them in writing, and these will be posted on the CIDC website a little later. Here you can see the address on your screen. Now, once again, the webinar will be recorded, and this recording and the slide set will also be available on the CIDC website. Before we move on to the presentation, I'd like to request that all participants complete the webinar evaluation. On this slide, you can see the link for the brief evaluation survey. If you registered with your own email address, you'll be sent an email following the webinar with the survey link. But if you didn't personally register, but say you're joining others in viewing this webinar, you should take note of this address so you can complete the evaluation and then receive a certificate. We cannot emphasize enough the value of your answers to the survey, as they do help set direction for upcoming webinar topics. Now I'd like to welcome our moderator for today's webinar, Dr. Marc Steben. Dr. Steben is the chair of the Canadian HPV Prevention Network and is also a family physician with the Family Medicine Group 1851 in Montreal. So welcome, Dr. Steben.
Thank you, George. And hello, everyone. I'm very pleased to serve as moderator for today's program and to be able to work with such a knowledgeable expert on HPV and RRP, Dr. Paolo Campisi. Dr. Campisi is a professor and vice chair education of the Department of Otolaryngology, Head and Neck Surgery at University of Toronto, practicing as a pediatric otolaryngologist at the Hospital for Sick Kids children in Toronto, Canada. He has a clinical interest in disorders of the airway and voice, and is the director of the Center for Pediatric Voice and Laryngeal Function, a subspecialty clinic designed for the care of children with voice disorders. His research interests are focused on the epidemiology and management of recurrent respiratory papillomatosis, or RRP, in children. Welcome, Dr. Campisi.
Thank you, Dr. Stebbin. It's a real pleasure for me to be here and to share my experience in dealing with this condition, and to share also my passion for finding a solution for these children that suffer from this terrible condition. I wish to also thank the CIDC and the sponsors, and George for putting this together and for allowing me this opportunity. So we are going to talk about recurrent respiratory papillomatosis in children, and we already heard about what the objectives are going to be. But before I begin, I know we usually start with the acknowledgements at the end, but I'd like to start with the acknowledgements up front. Because much of the work that we are going to present today really came about from a collective of individuals, researchers, and clinicians that share this passion and have allowed me to collect data at the national level, which is very unique compared to other countries around the world. And I also wish to disclose that part of this work was funded by a research grant from Merck Canada. So the objectives, essentially, we are going to introduce recurrent respiratory papillomatosis and how it affects children, risk factors for transmission, and to spend the majority of our time reviewing the national database that we have put together, which has also allowed us to continue surveillance to see if the HPV vaccination programs have made an impact on the incidence and prevalence of the disease. So I guess no presentation on HPV could possibly start without a slide like this, which describes the virus and that there are many different subtypes. And I've underlined HPV 6 and 11 because this is the link. These are the subtypes that are most often associated with external genital warts, but they are also the two almost exclusively causing recurrent respiratory papillomatosis. And so there is this important link, and why we are interested in vaccination programs that were not really intended for this condition, but may have an impact on this condition. So there are the HPV-related diseases, and there are many of them. This is not an exhaustive list, but I've highlighted the areas that I wish to focus on, and that is recurrent respiratory papillomatosis. And you can see on one of the photos there a larynx that's involved, but also of interest, and it is gaining more traction and interest at some of the traditional meetings that didn't talk about head and neck malignancies like Eurogin and the IPVC conference, where there's more and more interest in head and neck cancers, in particular tonsil and oropharyngeal cancers. So juvenile onset recurrent respiratory papillomatosis, as rare as it is still the most common benign laryngeal neoplasm in children. And there really are three clinical subgroups for RRP. There is, of course, the juvenile onset, which we define as a child developing this condition before the age of 14 years of age. There is the adult onset, and then, of course, there are those pediatric cases that can persist into adulthood. We believe that children gain this condition through vertical transmission from mother to child. Mother usually has a history of active genital warts or of infection. And exposure, we believe, is mostly due to vaginal delivery, but is not necessarily the only way. In utero cases or in utero exposure probably occurs because we have some children that were born by cesarean section that still acquire this condition. And again, as I mentioned before, it is caused by HPV 6 and 11. Now, I said it was a rare condition, and there are definitions that have been put forward by the United States, Japan, and the European Commission on Public Health, and the definitions are there, and clearly, juvenile onset RRP falls under these categories, that it is in fact a rare condition. And I've taken the liberty of trying to summarize the reports that have been published out there on the incidence and prevalence. And you can see there for Canada, the incidence is 0.24 per 100,000 and prevalence 1.1 per 100,000 children. And that number is pretty consistent with other reports in other jurisdictions in other countries. The American incidence is a little bit higher, and there are reasons for that, which I won't go into now. So again, we talked about vertical transmission and the risk factors. There is a high-risk triad. So vaginal delivery, especially if there are active warts at the time, and some studies have even shown that a long labor can also increase the risk. It's almost universal that we see that the mothers are very young, and it is their firstborn child. And they've also have studies that have reported specific HLA alleles or some kind of genetic predisposition from an immunologic perspective that can make you susceptible to the condition. So this is a bit older data. This is an older paper from the US Task Force on RRP, and it really describes the peak of the incidence of this condition in the United States. And in this report from 1993 that was published in 95, they reported more than 2,000 new cases per year. And that's where they got their incidence of 4.3. But it was really based on an extrapolation from centers that were interested. And I think this number is probably higher than it really should be. Nonetheless, they estimated that the potential cost was about $109 million per year to treat these very few cases. So it is an important condition with a significant economic and burden on patients. As I mentioned, it was numbers derived from 22 academic pediatric centers, but these are high volume centers, and I think this resulted in an overestimate in the incidence of the disease. But there was still some very important information that came out of that study. We know that the mean age of diagnosis is young. In this study, it was 3.8 years, and that the condition will likely last for at least 4 years, and then it starts to burn out. And the children may require multiple procedures during the course of the disease. We also know that the younger the children present, the more likely that they will require multiple procedures. So presenting at a very young age is a poor prognostic sign. Now, how do the children present? Well, many of the times they are referred to us for hoarseness or noisy breathing, and many times they are misdiagnosed as either having vocal cord nodules, which is very common, or of having asthma. But unfortunately, it doesn't go away with treatment, and they eventually make their way to our office. And when we examine them, we typically see the picture on the top, which is papillomas over the vocal cords and really compromising the airway. But unfortunately, sometimes they can present with severely advanced disease, as shown in the lower item on the left, where you can see that there is a distal tracheal involvement, or even worse, bronchopulmonary involvement, which can even result in a malignant transformation, as you see in the X-ray that shows the mass in the right lower lung, which ended up being a squamous cell carcinoma. Now, this slide shows risks of or other complications of distal airway spread and malignancy. And what you see in that last column of complications is that many patients have had a tracheotomy. So a tracheotomy is something that should be avoided at all costs in these cases. And there are still many places where they rely on a tracheostomy because they don't have rapid access to care. But we know that this will certainly increase their risk of having distal airway spread. So if I were to ever encounter a patient, I would do my best to control the disease and have the tracheotomy removed as soon as possible. So when they have the condition, how do we treat it? I'm not going to spend too much time on it, but there is a dilemma here. There are various thermal modalities with lasers. The list of them are on the left, and on the right are some of the more traditional techniques of cold metal debridement. Why do we have this conversation? Well, there are advantages and disadvantages to the two, but really what we're trying to do is get the better voice outcomes, because better voice outcomes is what really drives the quality of life for these patients. And so we want to find a technique that's the least injurious to the levels of the vocal cords so that they get the best possible voice, because we know they're going to likely require multiple surgical procedures. And so this is a report from a study from my voice laboratory comparing the CO2 laser to a microdebrider, which is more of a cold steel. And when we looked at specific computer-generated aspects of their voice, we found that there was a significant improvement in measures such as jitter and shimmer, which is about frequency and amplitude changes, and noise to harmonic ratio, that they did much better when we use these mechanical forms of debridement rather than lasers. And so that's my usual preference. And as I mentioned, the voice is very important with respect to quality of life. Here is a study in adults that shows, again, that many of the patients, 70%, had voice dysfunction and significantly lower social functioning. So it's extremely important. And in children, this is again a study from my laboratory where we looked at health utility index measures, and we used various scales to measure it. That again, we found that the children had a significant impact on health utility. And I'll just put these in here where you can see the measure that we got was 0.76, which is really not that much different from cystic fibrosis at 0.73, where 1 would be perfect health and 0 would be death. So it is a significant impact of this condition on quality of life. Well, let's change gears now and talk about HPV vaccination, because that was really the crux of what we wanted to talk about today. Well, immunization programs are very important. There is no doubt that they are the most successful public health initiatives in children. And there are many success stories. And even in our specialty, the one that I'd like to remark on the most is Haemophilus influenza. So that's an infection that will cause epiglottitis. And you can see the epiglottis here is quite enlarged on the lateral view of the X-ray. And once this was introduced, it essentially eliminated the condition. And this was a condition that required tracheotomy for treatment. So immunization is a very good thing. But to be successful, you need to target individuals before exposure. A population-based approach is best for maximum and equitable coverage. School programs have been most successful, and this has been repeated over and over again in various jurisdictions. And you need to achieve a very good or high coverage in the target population. So this basically shows the countries that have programs, and in the red box, in the fine writing in there is Canada, and they introduced their vaccination programs in 2007. And what these two slides are going to show, and I'm not going to go into detail here, but I just wanted to describe that each of our provinces has established vaccination programs for males and females, and in some instances, even for some other high-risk groups. And these are some of the rest of the provinces and territories. And I've taken the liberty of kind of summarizing as much data as I could to give an estimate of the HPV vaccination uptake rates with a national average of about 69.5%. It's not 100%, but it's still a very good number. And we believe that this is having an impact on some of the downstream clinical conditions caused by HPV infection. And so I'd like to describe this in a little bit more detail. And so when you have an infection and you vaccinate, or before you get the infection, you're trying to prevent this, well, how does the infection cause juvenile onset RRP? Well, one pathway could be by infecting mothers, causing genital warts, and that somehow is spreading to the mother. And perhaps we could interfere with that through vaccination. But if we're vaccinating children that have not been infected yet, are we giving them some protection so that then they have their own children, they will not have RRP? So those are the two potential pathways. So let's try to answer the first one, the first pathway. Will it interfere with the incidence of genital warts? Well, I think the evidence there is quite good. This is data out of Australia, which shows that when the vaccination program was introduced targeting women under 21 years of age, that the incidence of the genital warts decreased precipitously. And males under 21 soon followed. But in other populations that were not targeted, men having sex with men category, they did not benefit from the vaccination. So it shows that it makes a difference. This is also from Australia, which shows a similar type of picture. This is more of the different age groups. So again, when we vaccinate the under 21-year-olds or the catch-up group, the 21 to 30-year-olds, they showed a decrease in the genital wart rate, but the older than 30-year-olds that were not targeted did not show the same decrease. Other jurisdiction in Denmark, they had national programs and catch-up programs, and what they found that eventually they had no more cases of them, and the hazard ratio just improved and improved. So again, more evidence of improvement. And closer to home, this is a work published by Dr. Stebbin, our moderator, looking at prescriptions and ICD codes for the diagnosis of it. And we compare 2006 to 2012, that the women that were targeted showed, again, a decrease in the genital wart rate. In another study by Dr. Stebbin, just looking at the genital wart reduction, again, the panel on the left, or the graph on the left, shows that this was the case. There was a definite decrease in more than one province. And then for age groups as well, the first age group of 15 to 19-year-olds showed the most decrease in the incidence of genital warts. So the evidence is pretty clear in various jurisdictions that it's going to have a disruptive pathway on the genital warts, and will that have an impact on RRP? So that's the real question. Well, let's look at the data. So the Australians are also interested in doing this, and they are basically sending out a survey or a report card to about 1,400 pediatricians and pediatric otolaryngologists, and they get a pretty good response rate from this surveillance approach. And what they found was that the number of cases has started to go down. Now, they're really only, they're not looking at the whole country, but they are grasping a good proportion of it. And the incidence, the reported incidence, is dropping down significantly. Now, it's not population level data, and you need to be careful with that with rare conditions, but the evidence is starting to suggest that it is going down. Our colleagues in the United States are also interested in this. This is a study sponsored by the Centers for Disease Control, and Craig Durkee, as the lead of the RRP task force, is trying to answer that very same question. And he does have funding in place, has recruited several centers. Again, it's not at a population level, but these are more of the higher volume centers dealing with this condition. And they're starting to get some baseline data, and they know at least what their prevalent cases are. They know that the median maternal age at delivery was 21 years. Remember what I said before, that they are very young, and that this is usually their first delivery, first child. And again, HPV 6 and HPV 11 are predominantly the subtypes responsible for this condition. Well, we have a bit more data in Canada, and this is how we accomplished it. We recruited 12 centers, and it turns out that all of these patients are treated at one of these 12 centers. So with good confidence, we know that we are capturing the majority of our patients. Now, pre-vaccination, 1994 to 2007, the vaccine was introduced in 2007, we identified 243 patients. It's not a lot, but they underwent more than 3,000 surgical procedures. And based on our census data, we were able to measure the incidence and prevalence at 0.24 and 1.1 per 100,000 respectively. And when you look at these graphs, this is one of the dangers of studying a rare disease, is that you can see that the incidence year over year fluctuates. It changes over time. Prevalence not as much, but incidence does. So when you look at the Australian data, you have to be careful if you're only looking at a few years that you may get natural variations in time. So you really need to look at it over a longer term. So that's what we started to do. And we've now collected data for 10 years post-initiation of the vaccination, and we broke it down into 5-year aliquots. It was just easier to do that with a rare condition, and it was just most cost-effective to proceed with the study in this way. But we made sure we used a consistent approach, the same report form, the same reporting mechanism, the same collaborators over the 10 years. And we were able to measure the incidence and prevalence change over those 10-year period. So let me just talk you through this chart here. So here are our centers. These are the number of cases, the first column, identified pre-vaccination. There were the 243 total. And assuming we had a stable incidence and stable population over time, we predicted the number of cases that we would expect to see during the first 5 years. And that's what this second column is. But this is what we observed, and I'll highlight some of the important ones, where you could see that in the University of British Columbia, they observed 5, but they expected to have about 13 cases. In Toronto, where I work, we were expecting 30, but we only had 13 new. So overall, we were expecting 86, but only found 51. And that is significant. That's only 58.8% of the predicted number. So already in the first 5 years, we were starting to see a difference. And the incidence had decreased by about 20-25% down to 0.18 per 100,000. And the average age of the mothers was 21.5. And that's important because that means that it's not that those mothers were vaccinated. In fact, they weren't. It was rare that they were vaccinated. So this is more of that herd immunity effect, the decrease in the general wart rate in the population that was likely responsible. Here it is showing the data in a different way in graphical, that you can see that over time, the incidence and the prevalence was decreasing. The prevalence also dropped by about 20-25%. Now, what about the next 5 years, 2013 to 2017? So remember, this is still the column of what we would expect to see, but this is what we observed. And that number now has gone down to 33, which is an incredible drop, a very surprising drop. So we only have one center that's still waiting to report their numbers, but they are a small volume center. We don't expect this number to change much, but we only had 38.5% of the predicted incidence. So this is a very marked decrease. It's very exciting, and we are hopeful that if we continue to advocate for vaccination, we will make a difference. So looking at that data, was the decrease in incidence and prevalence, was it due to some random temporal variation? Well, perhaps, especially if you're only looking at a short period of time. But now that we have a total about 24 years of observation, that it's not likely due to random temporal variation, that this is a true effect. Now, is it direct effect on the females and protection to the fetus? Again, unlikely, because many of the mothers of the children that we are detecting now were not vaccinated. So we believe that it's rather this herd immunity effect by decreasing the incidence and prevalence of HPV infection in the population. So this begs the question, what will the next step be? Well, will this change in RRP also bear truth in a change in head and neck cancer, in particular for tonsil and base of tongue cancer? Well, this is something that needs to be studied. It needs to be monitored. It typically takes a lot longer to develop head and neck cancer, but we do need to keep track of this. And this is particularly important when you look at statistics out of Ontario that are looking at oral cancer rates in men. And for the first time ever, the curve that represents HPV-related cancers versus HPV-unrelated cancers, which are the typical smokers and drinkers, which is the pink one, that line has now crossed. And so we are having some good success with smoking cessation programs, and those cancer rates are going down, and they are now for the first time surpassed by HPV. So this is a really important opportunity here to advocate for vaccination, which may translate into decreased rates of oral pharynx cancer. And there's other evidence that supports that, that notion as well. This is a study that was not intended to answer this question. It was more looking at the bivalent HPV vaccine, and they did a double-blind controlled study, and one group received the HPV vaccine, the other received a Hep A vaccine. And then 4 years later, they went back and swabbed the oral cavity to look for HPV prevalence. And sure enough, the rate of oral HPV was far lower in the group that was vaccinated with the HPV vaccine. And so again, this is just more evidence suggesting that there may be a real opportunity here to make an impact on oropharyngeal cancer rates. I'm going to change gears a little bit because I think it's important to talk a bit about adjuvant therapies. You know, we're not very good at eliminating the disease once patients have the disease. And in some cases, the condition can be quite severe. But for those patients that have it, we need to find ways to manage it. And the reality is that this is not a surgical disease. We are not going to be able to eradicate this condition by inventing a new laser or a new mechanical debrider, but it's really a medical condition, and we need to understand this. Well, one of the areas that has gained a bit of interest right now is bevacizumab, which is a recombinant monoclonal antibody to vascular endothelial growth factor, or VEGF, and it inhibits angiogenesis. And that's probably important because when you look at the papilloma histologically, there is in fact a vascular core, and it likely blocks the development of this blood supply and allows the tumor to regress. This is an off-label use. I'd like to make sure that I emphasize that. And there are many risks that are associated with this use, such as hypertension, proteinuria. So if this were to ever be given by an otolaryngologist, I strongly advise that you team up with your oncology service and monitor the use of this medication very closely. Now, it was the systemic use. This is not the local injection into the larynx, but systemic use was first reported by a group in Germany, and they really focused on more adult patients. There was one child, but with very advanced disease. So these are patients that have distal airway or lung disease. And so this was more of a last effort to try to keep these patients alive. And they tried a treatment protocol, and they had very good success. A similar report was introduced by Karen Zur from Philadelphia, looking at a 12-year-old female that again had very advanced laryngeal, tracheal, and pulmonary disease. Also a history of a tracheotomy, tried many other medications, but really had to do this as a last-ditch effort to keep the child alive. And remarkably, it was able to prevent the condition from deteriorating and getting worse. Now, I had a similar patient, but it was very severe disease, but fortunately limited to the larynx. And it got to the point where this child required more than 60 procedures, sometimes every 2 weeks. And we really weren't gaining anything, and we were concerned that we were developing stenosis from the repeated surgeries. So we decided to really try something different, and we tried systemic bevacizumab. And so this child basically went from every 2 to 3 weeks to really not needing surgery now for over 2 years. And these are a series of photos that show that the papillomas, there's maybe a little bit right here, but essentially the vocal cords are open and the trachea is open. And I think this really represents a potential of a paradigm shift on how we treat these patients. We typically reserve these medical management for when the condition is so advanced. And perhaps we need to rethink that. And maybe we need to reintroduce these medications earlier on so that we can prevent those devastating complications of distal airway spread. So in other words, let's be more aggressive up front, and perhaps we can save more lives and give a better quality of life to these children, such as this one here, who had more than 60 procedures and now has had none in over 2 years. So this is very exciting, and I did want to spend some time to introduce that concept. So I just want to summarize here that we're not very good at treating the condition. It is a very devastating condition that has a dramatic impact on quality of life. But the real important message here is that it is a preventable disease. And vaccination certainly plays a role. And the Canadian experience has demonstrated that it can have a significant impact on the incidence and prevalence of this condition. A 61.5% decrease in incidence in the first 10 years. I think that's truly a success story, and it's a message that we need to get out there. We need to publish this. We need to give the evidence to stakeholders, in particular our public health colleagues, to continue to strongly advocate for vaccination, not just for the RRP, and as I mentioned before, there may be a potential impact for the prevention of head and neck cancer. So that's all I wanted to say today. I know that was a bit of a whirlwind, but I think this is very exciting, and we certainly have an opportunity here to make a large impact. So with that, I'd like to turn this back over to Dr. Steben to moderate some of the questions.
Thank you, Dr. Campisi, for providing a very interesting discussion of the relationship between HPV and RRP, and especially the JORP National Database. If our audience has any questions, please type them in the question box and send them in. We will now move on to the question and answer period. So we have a question from Dr. Durand. How is adult onset RRP different from juvenile onset?
Well, probably the most obvious is how it was acquired. Most of the time, the adult onset RRP is more of a sexual contact that has resulted in inoculation of the tissues of the upper airway. So that's a big obvious difference. The other is usually the severity of the disease is not as marked in adults as it is in children. Typically, children is probably more because of their very small airways. Are susceptible to airway obstruction and will require more frequent procedures. Although in adults, the condition may be severe as well. But in general, it is not as aggressive as it is in children. And then the other big difference is how you manage it. And in the adult world, they are able now to manage a lot of these debridements in the clinic. And so the patients are not necessarily put to sleep, but they can be managed with in-office lasers and local anesthesia. I don't know if that answers your question fully, or was there a specific aspect of the difference between the two? We know it's caused by the same virus. We know there obviously has to be contact with the virus, but the mode of exposure is clearly different.
Question from Carmen David. Is it beneficial to vaccinate a child who has a history of RRP?
So my simple answer to that is yes, absolutely. So all of the children that are diagnosed in our clinic, we certainly advise the families that they need to vaccinate, because remember, the purpose of the vaccination was really not about RRP, but about all the other conditions, all the other anogenital cancers that can occur, and there are many other subtypes of HPV, and so there is absolutely value in vaccinating. Typically, I just say to continue with the regular schedule vaccination that is in your jurisdiction. Some families also opt to vaccinate in the hopes that it may have an impact on the severity of their condition. Typically it does not, and it's kind of beyond the purposes of this webinar, but you know, there are immunologic reasons why a prophylactic vaccine will not eradicate the disease.
Thank you. So that brings us to when to vaccinate. Linda Taylor asked, so that brings us when to vaccinate: mom, dad, baby at birth, children age. What about incidental non-sexual contact where caregiver exposes unknowingly during toileting? So there are two issues: when to vaccinate and incidental transmission, non-sexual contact.
Okay, well, in terms, I think the recommendations that are out there currently are the ones that we should follow, and that is that vaccination should occur before sexual debut in order to get the full advantages of vaccination. So I think that's, you know, the general principle that you should follow. For children or even adults that are presenting with laryngeal papillomatosis, again, the belief is that the vaccine will likely not have an impact on the disease. And that is because the immunology is different. So increasing the amount of antibodies circulating will not eradicate infection that is clearly established in the basement membrane layer of the epithelium. There are some anecdotal reports out there that say that vaccination can have an impact, and they are anecdotal, they are uncontrolled studies. And as a member of the RRP task force, our general consensus is that if the families want it, it is okay to give it. There's probably not much of a downside to giving it, but I think counseling the families that the expectation of it you know, having a big impact are not realistic. So hopefully that answers the first question. In terms of casual contact, of all of my years in practice, I have never seen or heard of another family member acquiring the laryngeal papillomas through casual contact. And so I think that there is no risk of that unless there is a direct inoculation with injury to the epithelium. That's what usually causes the virus to cause an infection. And this becomes an issue where families come in where the school is concerned, the teacher's concerned, there may be other parents that want to know if it's safe to allow the child to attend school and will they infect other children. Again, to my knowledge of all the children I've treated with this, I've never had a case where someone acquired it in a casual way from attending a classroom with a child with the condition. So I don't think that there are any extra safety precautions that need to be taken with these children. Now, whether or not, if they still have active disease and they become teenagers and become sexually active, that it may be appropriate to have a conversation with those adolescents and young adults to make sure that they're fully aware of the risks that they may pose to their partners.
We have another question from Kimberly Kirkpatrick. Do you suggest a closer follow-up of child born to a mother who has a history of genital warts?
I think that one of the first things that happen if a child were to acquire the condition, they will get a hoarse voice. So general principles that we follow is that any child that has an unexplained hoarse voice for more than 2 to 4 weeks, then a referral to an otolaryngologist is in order so that we can assess the vocal cords. We can easily visualize in the clinic. You don't need to be under a general anesthetic for that. Now, do all children that have a parent with a history of HPV infection require endoscopy? Probably not, because as we know, the prevalence of HPV exposure is so high, we basically would be bringing every child into clinic for assessment.
Another question by Parm Randy. I work in public health and curious to know if it is possible that an exposure occurred in childhood, juvenile, but overt symptoms did not occur until early adulthood?
I guess anything is possible, and you know, you may have, the other thing I didn't mention is that there's also a possibility that a child that presents, say, at 7, 8, 9, 10, older than the typical 3 to 4 years of age, you do also have to consider sexual abuse as a potential way of being exposed. Now, in terms of having a latent infection that remains latent until later, I imagine that is possible. We certainly see that in some of our female children that may have had the disease, might have been a mild form, then goes into remission, so their immune system is keeping control of it, but then later on in life can have a relapse. And one of the times that they have relapses is during pregnancy. So what happens during pregnancy? Maybe there is a change in their immune system, maybe there's a change in their hormonal system, there clearly is. We don't know what the cause is, but there may be a relapse. So it is possible that you could have a latent form that becomes reactivated later. Anything that impacts your immune system can cause a latent infection to recur.
Linda Taylor asked, I'm thinking of the child getting contact from caregiver, not the other way.
From the caregiver, again, I've not had any children. It's hard to prove how they got it, but I've not had a child of a parent with laryngeal papillomas, put it that way. So I am not aware of that, but I guess could it happen? I guess anything can happen if you inoculate whatever you're shedding virus and you inoculate the child. But again, it's not just exposure. There has to be injury to the epithelium. But in my experience, I have not seen that.
What is the earliest age that the vaccine can be given?
Well, there's the guidelines that come from your own jurisdiction, but the youngest that I've given to, well, that patient that I mentioned, my severe patient, they were vaccinated and they were about 2 years of age. So that's the youngest experience that I have, and it had no impact on the disease.
There's the following question. Can it be recommended in children born to high-risk mothers which have not had vaccination or had worse in the past?
Yeah, that's a great question. In fact, there was some discussion at the RRP task force group of whether or not we should have a study where, the babies are given the vaccine. There were a lot of concerns about ethics and having such a study approved, but we have contemplated that very same question. It's a good question. I don't know the answer to it, but if we do identify a very high-risk child, it might be worth something to consider. Again, if you are going to do that, I think you need to do that with your infectious disease specialists and immunologists and have a conversation, and certainly not as an otolaryngologist, I wouldn't feel comfortable recommending that vaccine to an infant.
Children, do they carry the HPV for the rest of their life?
That's a great question as well. And in fact, I'm reviewing a paper right now, so I got to be careful how much I say here, where they've looked at the prevalence of HPV in the oral cavity of children, and there is a certain rate of positivity, but it's very, very, very low. I got to be careful. I can't say any more than that. It's unpublished data.
And what about a therapeutic vaccine? Do you have any idea if we are going to have some therapeutic vaccine?
Well, there are groups that are working on this. Much of this work is coming out of Johns Hopkins University. They have several in the pipeline that they are developing, and the whole goal there is move away from humoral immunity. So the prophylactic one is really stimulating the antibodies, and that's not going to help with established infection. So you need something that's going to boost the cellular immunity. And there are some vaccines that there are reports out there of very early studies that are in development. So I think that's going to be part of the answer here, not just the Avastin that I talked about. And perhaps maybe it's a combination of the two, of hitting aggressively medically with immunoboosting of some form to help eradicate these diseases. Great question.
Any thoughts about, any thoughts about the use of interferon? For a while it was popular for adults, for genital warts. Any work with interferon?
So I did use it on my patient. I don't know if you mentioned, if you noticed that on the slide, that he was on it for about 2 to 3 years, and it worked well. So interferon, the older forms of interferon alpha, there is a risk in children under 2 years of age of causing transverse myelitis and other neurologic conditions. So you have to be careful with that. There is a new form out there now. It's a pegylated form, which has less side effects, safer profile, and I used it in my patient, and it helped him to go from every 2 to 3 weeks to every 3 months. But then once that stopped working, eventually it stops working, and then you need to find something else. So yeah, there are reports on use of interferon. It's not used commonly. I'd say the most common one right now is cidofovir, which is an antiviral.
Carmen Bentley asks, what, if any, are the transmission risk intra or post-operative during a laser procedure?
Another great question, and there's some recent literature on this. So whenever you use a laser, there is always an occupational hazard risk, so to the surgeon, to the nursing team, to the anesthetist, and there's also a theoretical risk to the patient. I'm not a big fan of lasers for various reasons, and this is one of them. We don't have the data to say this is the absolute risk percentage. I don't know what that is. However, in one of the studies, what they did is they swabbed the masks and the gloves of surgeons and OR personnel in otolaryngology, in urology, obstetrics and gynecology, and what they found was that they were able to identify viral DNA on the masks and on the gloves, and so there is a potential risk to healthcare providers, and therefore, I guess if there's a plume, there's even a risk to the patient. And what those studies have prompted now is whether or not we as healthcare providers need to be vaccinated as well.
Myriam Beaulieu-Cyr asks, if a mom had the HPV as well as the vaccine, does she transfer the antibodies, her antibodies to her baby?
Yeah, again, wow, we're getting amazing questions today. There is literature out there that has shown that mothers that are vaccinated do express antibodies, and that antibodies do cross the placenta and make their way into the child. So yes, the answer is yes. There is some a protective immunity.
There's a question from Adekunle Sanialu. Has there been cases of remission? So I believe it's meant spontaneous remission.
Sure. So in one of our own studies, we just looked at the natural history of the condition. And what typically happens is that about 2/3 of all patients, even if you give them no adjuvant treatment, 2/3 of the patients will improve on their own over time, and a certain proportion of them will go into remission. And we're not sure what happens. Is it their own immune system that is just becoming more effective? It's controlling it? I don't know. But yes, there are cases of remission in children.
So we don't see any more questions.
Great.
So maybe I'll return the microphone to George. So thank you, Dr. Campisi, for the excellent presentation and for the answers that you've provided.
It has been my pleasure. I've had a great time. Thank you. And thank you to all our listeners.
So George?
Okay, thank you very much, Dr. Staban, for once again sharing your excellent moderating skills. I would also like to thank Dr. Campisi for taking time out of his very busy schedule to be with us today and for his support of CIDC's Continuing Medical Education series. I'd also like to express our appreciation to the partners who allow us to bring this webinar to you at no cost. That is Merck Canada, BD Diagnostics, and Immunize Canada. Now, to our audience members, please note that this webinar has been recorded and the video recording and the slide set will be available on CIDC's website in the coming few days. These and other resources are available on this website, and you can see the address on your screen. We also encourage you to join the Canadian HPV Prevention Network if you're interested in HPV issues. And this is a free network of interested clinicians, researchers, educators, and others. Simply go to the CIDC website, there again is the address, and send a message in the contact form. CIDC is preparing upcoming continuing medical education webinars, and we appreciate the input from our participants who suggest future webinar topics in our survey. So please remember to complete the evaluation form by clicking on the link in the follow-up email that you will receive shortly. So stay tuned for future CIDC webinars. Thanks for your interest, and please enjoy the rest of your day. Goodbye.